Thank you very much, Professor Ale, for being here and for having this session among the program of the Egyptian Society of Colorectal Surgeons. I'm happy that we are ahead of schedule by probably 3 minutes, which is very nice. So today I'm going to talk about the enhanced recovery after colorectal surgery, and probably, Dr. Ale mentioned that it's important in a low-income country and the middle-income countries much more than advanced countries, because actually one of the aims of the ERAS protocol is to decrease the cost. So let's look to the dogmas. The dogma is a principle or set of principles laid by the authority as incontrovertibly true. So let's look at the dogmas of colorectal surgery. You need to have a preoperative prolonged fasting, and probably postoperative, a nasogastric tube, drains, and prolonged bed rest. These were the dogmas in colorectal surgery. But we all know that evidence always trumps dogma. So we found that when you apply the ERAS protocol, which is a multimodal perioperative care pathway designed to achieve early recovery after surgical procedure by maintaining preoperative organ function and reducing profound stress response following surgery. It was initiated by Professor Henrik Khaled in 1993, under the name either Fast Track Protocol or Enhanced Recovery Program after surgery. And the aim of the ERAS is to minimize the stress response to surgery and to avoid iatrogenic problems such as postoperative ileus, and to speed the recovery and return to normal function, and definitely to have early recognition of abnormal recovery and intervention if necessary. In order to do this, we need to optimize preoperative preparation for surgery. So implementation. Studies have noted that after implementation of the ERAS, there is a fall of the surgical complication as well as the non-surgical complication as the nosocomial infection in the postoperative period. Successful implementation of the ERAS program reduced the duration of hospital stay. And when we reduce the duration of hospital stay, so if you are in a country where you have limited beds, probably it's going to help you. And definitely it will decrease the cost. ERAS is associated with better quality of life outcome when compared to a traditional care. A patient who is staying in a hospital for 10 days, off work for 1 month is totally different from a patient staying in a hospital for 3 days and off work for a week. Early discharge means the patient turnover time are reduced, and the institutes may be able to serve more patients within the available infrastructure, and this is important in low-income countries. So, in order to have a ERAS protocol, you must have a team to apply the ERAS protocol. You must have a team to apply the ERAS protocol. You have to have a pathway coordinator. You have to have a surgeon lead, anesthesia lead, nurse manager's surgery ward, clinical nurse specialist, and probably pain specialist, physiotherapist, nutritionist, pharmacist, and librarian. And we are going to see why. Because the ERAS got 3 phases: the preoperative phase, the intraoperative, and postoperative. And we are summarizing this in this, in this graph. Preoperative, you need to do optimization, you need to do prehabilitation, probably bowel preparation, reduced fasting, carbohydrate loading, and to be minimally invasive, and to have intraoperative fluid balance and normothermia, and maybe regional anesthesia. We're going to talk about them one by one. For the preoperative, patient counseling and education is very important because it decreases the fear and the anxiety. Plus, you need to do stoma education if the patient is going to have a stoma at a certain point of the surgery, either during the surgery or if you're expecting it to do it after surgery. Preoperative optimization, assessment and control of the medical condition is important. If you decide to do bowel preparation, it's time to tell the patient to do it preoperative. Thromboembolic prophylaxis is important. Preoperative fasting, so you need to have a carbohydrate loading. A patient can have clear liquid until 2 hours before surgery. For the solid diet, 6 hours, and they must have a high carbohydrate diet. Antimicrobial prophylaxis, 1 hour before skin incision, and you repeat it if the surgery continues more than 4 hours. For the intraoperative, you must have standardized anesthesia protocol according to your anesthesia consultant. The surgical approach, you need to decide it. Are you going to do it laparoscopic or hepatic? And if you're going to do open surgery, like in emergency, we have some certain precaution for this. Fluid management is important because some anesthesia believes that the kidney can do everything. Actually, the kidney can do just limited things. It can remove certain amount of fluid from the body, but you cannot give the patient 5 liters in 3 hours and you're expecting the kidney to remove them. Prevention of intraoperative hypothermia is important, and pelvic drainage is questionable. So the fluid, I'm going to talk about the fluid management. If you are having hyper or hypovolemia, so you are expecting to have a splanchnic hyper or hypoperfusion, and both of them lead to ileus, with increased morbidity and increased length of stay. So probably the goal-directed fluid therapy with the intraoperative Doppler to maintain the intravascular volume is important. Cardiac output and tissue perfusion while avoiding fluid overload. Monitor the urine output. Sometimes it's difficult. Alternatively, you can have a CVP. You examine the heart rate and the arterial pressure, so arterial line. Hypothermia, usually if you have a prolonged exposure, temperature drop below 36. And there is increased possibility of wound infection, blood loss, and complication. And you need to maintain the normothermia using external heaters. I think all of us have it, you know, and warm IV fluid if you need it. First report about ERAS in colorectal, you know, in 2000, annals of surgery, 60 patient, open colon resection plus accelerated multimodal rehabilitation program. At that time, epidural, thoracic epidural were part of ERAS with early vida and mobilization. Median length of stay was 2 days. And they recommend only 15%, but it was high readmission, 15% readmission. At that time, it was really very high. I think now it drops probably 8%. So the results of application of the ERAS protocol is to decrease the length of stay, to decrease the cost of the healthcare system, and improve the surgical outcome. And for the function, there is decrease of the time of preoperative fasting, and decrease of the intraoperative fluid, and decrease the postoperative fasting, because usually the patient starts feeding if he is having minimally invasive surgery on the same day of surgery. For the complication, there is drop in the postoperative nausea and vomiting, drop in the surgical site infection, and drop in the incidence of ileus postoperatively. What's the economic impact of ERAS? And this is an important part in the low-income countries. The economic impact of ERAS protocol has been widely described in colorectal surgery. In Samor et al., were the first to demonstrate saving per patient of around $4,400. 2 systemic reviews, both of them in 2014. I don't know why they stopped doing it after that, concluding that the ERAS protocol was a cost-effective intervention in colorectal surgery with associated healthcare cost saving. And Finch studied the application of ERAS protocol applied in laparoscopic colorectal approach, observing that there is decrease of the hospital cost due to improved recovery and reduced health of stay. And this is a paper by Lee in 2014, and you know, you can see compare the patient with conventional pathway and enhanced recovery, and you can see in the conventional pathway, there is a higher rate of stoma, there is less rate of laparoscopic surgery, thoracic epidural was used as the same, normothermia probably the same, abdominal drain were applied in the conventional pathway, not in enhanced recovery protocol. And for the results, there is decreased length of stay as regard day to mobilization, day to discontinuation of IV fluid, days until the passage of first flightus, days until you receive oral fluid to tolerate solid diet, and removal of bladder cancer. Significant drop of all these if you are going to apply enhanced recovery protocol. And stay still with Lee, published another paper, total hospitalization 9.8 days without ERAS protocol versus 6.5 days with the ERAS protocol. I think all of us is having much less now. And 60 days readmission, 11%, you know, with the conventional protocol versus 13% in the ERAS protocol. So it was a bit higher, but it was not significant. And the complication rate, 43 versus 40, so no difference in complications. So the lost time of work, 35 days in the conventional protocol versus 26 days in the ERAS protocol. So there was decrease of the time of work with the ERAS protocol. So the mean difference in cost from different perspective per patient, institutional cost saving with the ERAS protocol around $1,000 per patient. Healthcare system cost saving around $1,600 per patient. And the society cost saving around $3,000 per patient. So if you, for example, this paper published about the ERAS protocol in oesophageectomy, not in colorectal surgery, and the expected cost saving per patient were around $2,600, and the average caseload around 50 to 60 per year in this institute, with a total saving of around $133,000 saving per year only for oesophageectomy, only in this institute. So the summary, in order to apply ERAS protocol, probably you need to change the culture, because we still have doctors somewhere asking the patient to fast 3 hours before surgery and 5 hours after, 5 days after. So I mean, we need to change this culture. We have to focus on the patient recovery. We had to get evidence into practice, so we don't read something and apply something else. We need to apply what we're reading, and improve the interdisciplinary environment, because as you said, as I said before, we have many persons should be involved, should be on board of applying the ERAS protocol, and applicable across the procedure, not only in a single procedure, and we have to decrease variability in application. And outcomes that matters is the patient outcome and the cost. My conclusions, ERAS should be normal in any clinical practice, definitely in colorectal surgery for us. It's evidence-based. It prevents catabolic state of the patient after surgery. It promotes early resumption of organ function. It reduces the post-operative complications, and it decreases the length of stay. And finally, it decreases the cost of care, and maybe that's why we feel it's important for low-income countries. Thank you very much.